Hello, and welcome to this presentation on assessing decision-making capacity, especially for dementia. uh, we can use this tool called Aid to Capacity Evaluation. It's important to have a systematic, formal assessment approach because this is a serious issue and there are various factors in the assessment, such as whether the patient understands what is being asked of them regarding their decision, whether they have an emotional appreciation of their decision, whether they can use reasoning abilities to explain why they chose a specific decision, whether they can communicate, for example, they do not have aphasia, whether the decision is stable over time, uh, whether there is any coercion involved, because it's important that the decision is non-coercive, and important to assess whether the decision is in alignment with their values and long held and expressed wishes. It's important to assume that all patients have decision-making capacity unless proven otherwise. Also, we need to realize that our patients are allowed to make any decisions, including unwise decisions and decisions that may lead to serious disability or even death. I have patients who do not want to stop smoking even when they have very advanced lung disease, patients who do not want to stop drinking even when they have end stage liver disease. Healthcare professionals have an ethical obligation to optimize autonomy and participation in decision making. Patients who lack decision making capacity cannot give informed consent for medical decisions. So, this is a big deal. We are taking away their rights to make informed consent. Also, decision making capacity is situation and problem specific. So, just because a person lacks their decision making capacity for deciding complex decisions, such as whether to use chemotherapy or radiation therapy for metastatic cancer, does not mean that they need a guardian. They could have problems with one decision making capacity, but still have capacity to make more simple decisions. Again, lack of decision making capacity may be temporary. In my practice, I've seen a lot of my elderly patients with delirium who do not have decision making capacity, but once the delirium improves, their capacity to make decisions returns. Most physicians are reluctant to assess decision making capacity because they lack training and experience. This is especially true for many primary care providers. Again, decision making capacity assessment is not assessment of competency. Assessment of competency is a legal assessment and requires judge and many other processes. Systematic formal assessment is needed in every case, as I mentioned earlier, and in some cases, we might need to do a very formal cognitive testing on the bedside, such as Montreal Cognitive Assessment, and also aid to cognitive evaluation may be needed. Again, we need to realize that we need to move to a more sophisticated approach from categorical and exclusionary practice towards a more dimensional and inclusionary concept of capacity, where we utilize concepts such as shared decision making, collaborative decision making, assent, appointing a supporter in decision making, right to take risks such as dignity of risk, and culture appropriate support. In a landmark study, it was shown that many patients in the hospital lack decision making capacity, and again, many physicians in the hospital do not identify these individuals very accurately. A lot of the physicians feel that the patient has decision making capacity when actually they do not have. This is especially true for patients with dementia. I mentioned that it's important to address understanding, appreciation, reasoning, and communication as the four key components of decision making capacity. In the textbook written by myself and my mentor, Dr. George Grossberg, we go into details about decision-making capacity in older adults and individuals in long-term care facility. Please check it out. Uh, Many patients with other conditions besides dementia and delirium can have impaired decision-making capacity, such as schizophrenia, major depression, intellectual disability, autism spectrum disorder, aphasias, and so on. Again, the mere presence of these illnesses does not mean that the patient has incapacity. There are pitfalls during assessment, such as many times the patients are not giving adequate information. We use many medical jargon. We need to keep all these pitfalls in mind. And we need to try and optimize the person's capacity to understand by ensuring that their hearing and vision deficits are addressed, their pain and other reversible conditions are addressed, and so on. A wise approach is to use the patient's instincts even when they do not have decision-making capacity or they have diminished decision-making capacity. Bottom line, we seek to work towards transforming our culture to one honoring human dignity. Let's be companions together on this journey. This is by Friedel and Bryden when they gave a talk at the Australian National Alzheimer's Conference. Both of them had early stage dementia. Making assessment of decision-making capacity is honoring our patient's human dignity. Let's do it very mindfully. Hope this has been useful. Namaste.